We are pleased to have Dr. Mario Zuccarello join us today to talk about the treatment of brain aneurysms. He is the director of the Brain Tumor Center at the University of Cincinnati Medical Center. Dr. Zuccarello specializes in the treatment of brain aneurysms and brain tumors. I bet you didn't know that he is also instrumental in starting the Tri-State Brain Aneurysm Support Group in 2002 and has been a frequent presenter at our conferences. He also continues to champion advocacy for survivors. Thank you so much for being here today, Dr. Zuccarello.
Denise, thanks so much. Thank you for the introduction. And it's always a privilege to present to this audience. And I hope this will be the last time we do on online, but rather it will be in person, which is much better than that. I remember the first symposium, April 23rd, 2005. And when we had the first symposium, we thought maybe this will be the only one, but in reality, it has not been the only one because it has been done consecutively now till 2022. And so I need to thank Roberta Holden, and of course you, Denise, and all the other presidents of Tri-State Aneurysm Support Group for really putting so much effort. So the treatment, this is a picture of a CT angiogram, and I hope you can see this is a brain aneurysm. This is the small brain aneurysm. You can see very well the blood vessels. So the brain vessels bringing more blood and nutrition to the brain are anterior in the neck and on the back of the neck. The anterior is called internal carotid arteries. On the back is the vertebral arteries. When they reach the brain, they split in several branches, and the two major branches anteriorly is the middle cerebral artery, the anterior cerebral artery, and the major one on the back is the basilar artery, and the other branch posterior cerebral artery. All these vessels are somehow interconnected, and so it's important to know that unfortunately if somebody loses one, there will be some help from the other one. So we know that approximately between 10 and 15 million people are affected by intracranial aneurysms in the United States. And the majority of these aneurysms are unruptured. And you can see a sketch here of this bubble, which is the aneurysm coming from this large blood vessels, which is the carotid artery. It's important to remember this, the majority are unruptured. So the location, the majority are the anterior circulation, which means in this area, anterior, so close to the eyeballs and the base of the skull. And the minority, about 15%, are on the back here on the basal artery. About 20% of patients also has a multiple brain aneurysms. So the diagnosis of brain aneurysms can be done in many ways. Even a CAT scan or an MRI can see aneurysms, depending on how large they are. The gold standard has been the angiography, the arteriography, but the MRA or CT angiograms can replace arteriography in many instances, and they are minimally invasive procedures. You can see on the MRI, for instance, a very large aneurysm. And this is the cerebral angiography, where you can see even very small aneurysm. You can see this bubble here and in the course of this blood vessel. And then the CT angiogram, where you can see even better these two aneurysms. And the MRA, you can see another aneurysm. So if there's any suspicion that anyone has a brain aneurysm, we have means to show and to detect and to alarm nobody but a warn, yes, because the brain aneurysm can be very dangerous, as you heard from, unfortunately, from the Denise story. So what I'd like to talk to you today in a very interactive fashion is the management and eventual treatment of unruptured brain aneurysms. Because like we said, the majority are unruptured. And if we can catch them when they are unruptured, of course, the outcome is completely different, totally different. The majority of patients are treated when unruptured aneurysms, they do extremely well without any problem, short-term memories or weakness or any problem, double vision, anything. But because the rupture is what makes really the story so complicated. So, and I'm trying to do this in a way that's too interactive. I put the questions that I have received from my patients in the course of the past 35 years. And there may be many, many other questions. And that's why at the end, there will be about 10 minutes. I hope even longer than that, because I try to be quicker than my time, where you can ask questions. So what causes aneurysm? That's the most frequent questions. So the aneurysm, nobody knows exactly what, but any condition which can cause the blood vessel wall to get weaker can be the risk of developing an aneurysm. And when people said atherosclerosis, which means the hardening of the blood vessels, or high blood pressure, this too has been related to the development of aneurysms. So if you have a diagnosis of high blood pressure, you need to be careful. You need to try to treat the high blood pressure because it could create the conditions for developing a new aneurysm. Even infection sometimes can lead to developing what they call infectious aneurysms. Not real, similar to the other one, but a little bit different. But at the end of the day, the result is identical. So one thing to remember is if you have a strong family history, which means more than one immediate family member with a brain aneurysm, you may be at risk to have an aneurysm. So if your mom and your sister or your brother has been diagnosed with an aneurysm, you better get checked because you could have an aneurysm. And if you know that in advance, like we said, the treatment will be much easier and the outcome will be absolutely different, will be perfect. If somebody unfortunately has a previous history of brain aneurysms, it can be a higher risk to develop another one. And there are some genetic factors, maybe not affecting the majority of us directly, but if you are from Finnish or Japanese ancestry, you have a higher risk to develop aneurysms. People who has what they call polycystic kidney disease, this is not so rare. It's a condition where the kidneys have a lot of cysts, and those patients has high blood pressure, and also they have a weakening of the wall of the blood vessels. Those patients are at incredibly high risk of developing new, constantly aneurysms. And then anyone who has like the EDS, okay, everybody knows EDS, which means Ehlers-Danlos syndrome, which is a dysfunction of a collagen, which is part of the wall also of the blood vessel. Those patients can have a higher risk of developing aneurysms. The female gender, unfortunately, has higher incidence of aneurysm. And then fibromuscular dysplasia, the FMD, sometimes is found on the ultrasounds and in the neck, because this is fibromuscular dysplasia of the carotid arteries. They've been associated with a higher risk of developing brain aneurysms. So there are a number of conditions which can constitute a warning sign. And so if anyone knows somebody else with any of those conditions, they should be pretty alert to that, better be checked and not be checked when the aneurysm ruptured. So these are the list of the must ask questions for an unruptured brain aneurysm. Can I leave it when I rupture aneurysm? Can a ruptured aneurysm go away? What are the symptoms of unruptured aneurysm? How long can an aneurysm stay unruptured? And what I do if I have an unruptured brain aneurysm? So I'll try to go through these questions, and I'm sure there will be more questions, and I hope you will ask me at the end. So starting with, can I leave with an unruptured aneurysm? Okay, so people definitely can leave for many years before even they are found. And many times they're found by chance. They have, I don't know, a head injury, for instance, somebody like that. They receive an MRI scan, and they can see aneurysm. Because the majority don't cause any symptoms. And essentially, they remain intact for a long time. So yes, it's possible to live with an ruptured aneurysm for the entire life, many times, okay? And many times they are found just by chance. So the other question sometimes you receive from patients is, can this ruptured aneurysm go away? Well, it's extremely rare, unfortunately. the chance that an aneurysm can disappear on its own without any treatment is incredibly rare. I've seen 1 or twice in patients, and what happened essentially is the small aneurysms, they develop like a clot inside the aneurysm, and this clot will seals off this bubble, the bulge, which is the aneurysm itself. But don't count on this. Don't count that the aneurysm will go away. Can happen extremely rare. The other question is, if I have an unruptured aneurysm, what should I watch for? What kind of symptoms? So, unfortunately, there are not specific symptoms. The many symptoms are really very common symptoms that patient has and people has every day: headaches, some dizziness, some eye pain, maybe double vision. But when you start having vision problems, or even double vision or seizures, that's, of course, is a different level of alertness. So the majority have no symptoms or some generic symptoms. Some, depending on the location of the aneurysm, can have very specific symptoms, particularly vision, particularly decrease in vision or double vision, or occasionally seizures. So unfortunately, there's nothing so specific. But if you suffer, for instance, of headaches, you have migraine, and then you have a sudden change in the pattern of your headaches, that could be something to consider to be rechecked. Okay, but unfortunately, the majority will not have any symptoms. So the question, which is a little bit redundant, but in a phrase in a little bit different way, how long can an aneurysm stay unruptured? Like I said before, people can live a long life, a long time with a brain aneurysm without any problem. And many of these aneurysms cause no symptoms. And many will live without knowing that. So it's impossible to answer the question, how long can an aneurysm stay unruptured? It's really impossible to answer this question because we don't know exactly what's the exact mechanism of rupture. We understand a little bit better why they develop or why they form, but why they rupture, it's really not very clear. There are a lot of theories, and I'd be happy to discuss a little bit more at the end, but nothing so clear-cut. What you like to avoid is exactly this. This is the bubble, which is the aneurysm, and this is blood coming through the aneurysm. You don't want to have this. You don't want to have a subarachnoid hemorrhage, because then, unfortunately, the story becomes similar to Denise's husband, becomes very complex with a lot of side effects. So I'd like to talk a little bit more about the risk of rupture of unruptured aneurysm. What we know about the risk of rupture. We cannot determine when they rupture or if they rupture, rather, but we can have a better understanding of the risk of rupture. So the risk of rupture is related to the size and the location. So we know that if an aneurysm is located on what we call the posterior circulation, remember the initial sketch, there are blood vessels in front, the blood vessels in the back. The vertebral arteries will merge and develop a basilar artery aneurysm. So the basilar artery is a place where the risk of rupture is much higher than other locations. So the location is very important. If you have a small aneurysm, which is on the middle cerebral artery, so anterior, the risk of rupture is very low. So, but in the posterior circulation, it's much higher. The other risk is the size, how big they are. So we know that if aneurysms are smaller than 7 millimeters, which is less than 1/3 of an inch, the risk of rupture per year is very, very low. Imagine 0.05%. So it's extremely low. But if an aneurysm get larger, over 7 millimeters, the risk of 1% per year. And if it's larger, it's like an inch, about 2.5 centimeters, so 25 millimeters, the risk is 6% per year, 6 times higher. So the size of the aneurysm, it's really important, and the location is equally important. Now, if somebody already had a subarachnoid hemorrhage from one aneurysm and already be diagnosed with second aneurysm, the risks are up to 11 times higher than if you had only one aneurysm. So if somebody has a subarachnoid from a ruptured aneurysm, which can be repaired, and they have a second aneurysm, unfortunately, the second aneurysm should be treated because there's 11 times higher risk of rupturing. So this is a big concept. So think about this. Locate where your aneurysm is located and how large it is. There's two things which are important to remember. And I will show to you these tables, and not because I want to confuse you or I go through all these numbers, but only to show to you there are several studies. This is the most famous study of unruptured aneurysms done in the United States. This is another one, this is another one studies. At the end of the day, the message is that the risk of rupture is by location and by size, okay? This is just a summary of what I said, and clearly, depending how large they are, there's a significant risk, like more than, like an inch is 6%, like I said, and so forth. Now, this is something which has been developed to try to help the physicians and the patient to make a decision whether to treat or not to treat an aneurysm. So this is called phases, and it's not a perfect way to try to prognosticate, to make an educated opinion on whether the aneurysm has a risk of rupture or not. But the population is important. Like, remember what I said before, if you have a Japanese or Finnish ancestry, you have a higher risk. The hypertension is important. The age, the size, like we said before. And then if you have a subarachnoid from another aneurysm, very important. And then the location of the aneurysm. So this is nothing else than putting together some of the stuff we already discussed briefly. So, and the higher is the score, the higher the chance to this aneurysm to rupture and so to be treated. So for instance, if you have a 1 for high blood pressure, maybe 0, but 1, your age is over 70s, and the size of the aneurysm is between 10 and 19. So you have 6, 7, 8, and then you have in posterior circulation 12. 12 is already pretty high score for the aneurysm to be treated. So this helps tremendously. It's not perfect, but give it to us a good idea of whether an aneurysm, which is not ruptured, it should be treated. And in fact, if you want, you can find this, the phases score calculator also online, and the highest score is 22. And if you have the highest score 22, which we can go back, 22 will be like your ancestors are from Finland, and everything is the maximum, like 10, 15, 16, 17, 18, and 4, and the posterior 22. If you have 22, the risk in 5 years is enormous. There's no way that you can avoid to be treated, because sooner or later this aneurysm will rupture. But if the risk is very low, 2, which again, 2 means 0, maybe you have high blood pressure is 1, and then this is 0, you're younger than 70, it's 0, and maybe as you have, I don't know, an MCA, maybe 2 or 3. In these cases, the risk of rupture is like 0.4% compared to 17 in 5 years. So those patients should not be treated, because the risk is so low that then it will not exceed the risk of a treatment, which is definitely much higher than 0.4% per in 5 years. And this is a calculator which is published, so anyone can have access if you want to, and I'm sure Roberta can provide this to you. So what I do if I have an ruptured brain aneurysm, that's the final question. So first of all, you need to try to eliminate the risk factors. Risk factors, then we know, and this is a study coming from University of Cincinnati by Dr. Broderick, done several years ago, that if you are a smoker, unfortunately, you have a high chance not only to develop aneurysms, but also to rupture. If you use a heavy use of alcohol, similar stuff. We saw that high blood pressure is another risk factor, not only in the development, but also in the rupture. And the lifestyle changes, it's important, because if you have a very sedentary life, the risk of having high cholesterol, the risk to have high blood pressure increase significantly. So a moderate, activity and with a cardiovascular so-called type of exercise will definitely decrease the risk of not only development of aneurysms, but also rupture. The genetic factor, unfortunately, cannot be changed. So if somebody is affected to be diagnosed with this PKD, this polycystic kidney disease, we just discussed it briefly before, or neurofibromatosis, which is another condition. If you have that, unfortunately, you need to have surveillance. And if aneurysms are found, it should be treated because there's a higher risk. And the most important, you need to have a consultation in a center with a multidisciplinary team, like you have a Mayfield Clinic, like you have University of Cincinnati, and many other places. A multidisciplinary team means a team which is made by physicians who can treat your aneurysms in a proper way, in a way that's best for you, with surgery, with coiling, with stenting, whatever it is, and comes from a approach which better suited your aneurysm. So that's very important. So when is the risk of rupture of a known aneurysm increasing? So that's important. Let's pretend that you have a 5mm aneurysm on the middle cerebral artery, and this 5mm aneurysm is considered really a small aneurysm. In the score that we discussed, maybe you are 4 or 5, so it's small, it's a low score. The risk of rupture is way less than 1%. Better not to do anything for now. Let's watch it. And you have either MRAs or CAT scan, angiogram, whatever, to monitor, okay? If we see a change in shape and in change in size, this is a warning sign, because a change in shape, a change in size means that the wall of the aneurysm is getting weaker. So that's very important. Second, I don't know if you remember what I said. Yes, headaches is very common, of course. But if you have a sudden change in symptoms, sudden change in the frequency and the durations and location of your headache, that can be a warning sign. Or if you have sudden onset of symptoms like double vision, for instance, or decrease in vision, that's just another possible warning sign which cannot be underscored. And I think Denise made a very good observation. You need to listen to your body, and so that's very important. And of course, you go in immediate consultation in a center with a multidisciplinary team. So, what the treatment options if you go and you are diagnosed with an unruptured aneurysm? The treatment option is observation number 1. What's the advantage of observation? Of course, the aneurysm has to be small, and the location where we discuss is not high risk of rupture. So the process, of course, you have no risk of intervention, and non-invasive MRA or CAT scanning angiogram can confirm the size, which is stable, so you can continue to have observation. The other side of the coin is the risk of rupture is variable and based on its size, location, age, like we said. So you can observe as long as the risk of rupture is low. And so you can have non-invasive type of monitoring. By observation, it's okay if you have very small aneurysms in a anterior circulation. That's, I think, very appropriate. Surgery. The pros on a direct surgical procedure is that 95% guarantee will not regrow and 99% guarantee will not rupture. So the surgical treatment is extremely effective and also is durable. because it will not rupture, and you don't need to retreat it. Of course, there's always on the other side of the coin, there's a risk of disability in terms of memory, thinking from craniotomy, which is about 10%. It's also a small risk of seizures because we need to go around the brain, not necessarily through the brain, but there's still risk of seizure. So surgery, in some instances, is very appropriate because it's extremely durable, and also is 95% guarantee will not regrow. And then you have endovascular treatment. The endovascular treatment has the big advantage to have a lower risk of brain disability versus surgery. However, the lifetime guarantee will not regrow is 80–85%, and like you were listen to Denise, and her husband had to be retreated several times, which is okay. But you know, it's certainly something to keep in mind. And you have about 90% guarantee will not rupture. So it's an excellent treatment in many instances, but it's less durable than surgical clipping. The disadvantage this is the risk of regrowth, of course, and if you have too many angiograms, which is the invasive procedures, at the end there's a small risk of strokes, which goes between 0.7 and 1% each time you do an angiogram. So you have a need of multidisciplinary, like I say, team, because they will give to you the best advice. And in fact, and I stay within my time assigned, and so we can have more questions, to determine the best management and eventually the treatment involve the knowledge of many factors. Remember, the location of your aneurysm, the size of the aneurysm, the shape of the aneurysm is important. Age, gender, genetics, family history. Remember, if you have 2 first-degree family members, that's high risk. Previous subarachnoid will increase the risk of the other aneurysm, which is not ruptured, by 11 times. And the overall, of course, health of the patient and medical history, it's also very important. So I hope I gave to you some answers to your questions, but I'm sure you're gonna have many other questions, and I will just let you now take advantage of the time that we have just to try to have a few more of those questions. Thank you so much.
Thank you, Dr. Zuccarello. That was an excellent talk. We do have a couple of questions for you. The first one is, I've read that a woman's risk of aneurysm increases after menopause. Is that simply due to age or also due to hormone changes?
First of all, unfortunately, the female gender has a higher risk in general of not only developing, also rupturing aneurysms. In fact, the majority of the statistics, you hear almost a 60-40, 60% are female, 40% male. So that's a very unfortunate disadvantage. So clearly, it's an hormonal phenomenon. And whether the estrogen, there's some studies about the estrogens, and so I think it's more hormonal than anything else. Now, the age factor, if you remember on the slide when I put all the scores, and if you're older than 70, they give you 1 point. So the age factor can play a role over the age of 70, but I think the majority of the explanation will fall into an hormonal issue.
Okay, our next question. If you've already had one ruptured aneurysm, is there a greater risk of having another?
The answer is yes. There's a slightly higher chance to develop a second aneurysm. And the reason is probably because, if you remember when I tried to explain why people develop aneurysm, the cause of development, okay? So if you already have developed one, you must have some already reason there. So as been reported, the risk to develop second aneurysm is about 2.5%, or 2.5 times higher than normal population. So there's a little bit of higher risk, yes.
Next question. Why are headaches common after rupture?
Well, that's is due to the fact that the rupture means the blood is going from the inside the blood vessel and outside the blood vessels. The blood vessels in the brain are into a space which is called subarachnoid space. That's why they call it subarachnoid hemorrhage. The subarachnoid space, under normal circumstances, filled with spinal fluid. So when rupture occurs, blood gets mixed with the spinal fluid, which is pure, perfectly transparent, much more than the water. Okay, so the mixture of spinal fluid with blood create a very irritant, inflammatory type of process. So the inflammation it will trigger the development of headaches, and in fact, the headaches remains for a long time after subarachnoid, and only when the washout of this blood, all this inflammatory small stuff, what they call molecules, the small stuff is totally washed out, then the patient start having less frequent headaches. But very unfortunately for whoever asked the question, sometimes headaches never completely disappears because the blood contains hemoglobin, and hemoglobin is big part of hemoglobin is iron. So iron is the heavy metal. The heavy metal stays in the space, the subarachnoid spaces forever. And the heavy metal, this iron triggers inflammatory responses. And that's why, unfortunately, some patients cannot wash out completely the blood, and so they have long-term headaches.
Okay, next question. Considering immediate family history with aneurysms, how often should other family members get checked, and what tests are recommended?
So if you have, like I said, two family members, mom and sister or whoever, close to you, okay, 1 degree. Like I said, there is a higher risk of developing aneurysms. So the first question, which is very difficult to answer, is when to get tested. And that's just very, very difficult. I think if your mother has aneurysms and your aunt, for instance, aneurysm, okay, it's your mother's sister, both, I would say that I would start having it checked after the age of 20, 25. If you have, younger, I don't think will make much of sense. The sad part of the story is the insurance very often will not really pay for that, for the screenings. Okay, there's a way, but to get approved, and so, but I think after the age of 25, that's could be reasonable. If you have a negative test, which one? I would suggest either a CAT scan angiogram or the MRA, one of the two. Okay, so it will be minimally invasive test and not angiograms, which is much more invasive. If you have a negative CAT scan angiogram or negative MRA, I would not repeat that probably for at least 10 years, and then maybe a recheck. Unfortunately, again, there's nothing scientifically proven how often you need to repeat a test. Absolutely nothing. So this is what I'm giving to you is my personal experience, which is not necessarily the correct way, maybe, but this is what I usually do. I would suggest. Now, this is a huge topic, screening, enormous topic. And several years ago, and Roberta remembers that, I tried to go to the city and the state, and we were decided to go to the government in Washington to try to convince people that screening when a patient is high risk is important. Unfortunately, I don't think it's been very successful. But There's a way, if somebody's high risk, that's a way to get a screening, and you need to talk to your physician.
Next question, does location of an aneurysm increase the possibility of specific side effects, for example, tinnitus, balance issues, or seizures? Or are these possible side effects from surgery itself?
Okay, so there are two different questions. Since we're talking about unruptured aneurysms, the location of an unruptured aneurysm can definitely determine the potential symptoms or side effect, or what you want to call it. So if the aneurysm is in a basal artery, the symptoms like dizziness or the tinnitus or tinnitus, whatever you want to call, is much higher than if the aneurysm is located in a carotid artery. Okay. The vision problems, so decrease in vision or double vision, it's much more frequent if the aneurysm is in a carotid. So location makes a difference. Now, the second question is if the side effect after surgery can be determined by the aneurysm location. The answer is yes, because if you have a large aneurysm next to your optic nerves, there's a chance then to have a decrease in vision. So the answer is yes. The location, it's important because will determine the potential side effects. Did I answer your question?
Yes. I have one last question.
Yes.
Is there a relationship between abdominal aneurysms and brain aneurysms? If my family member has aortic aneurysm, should I get screened?
That's a very, very good question, actually. Okay, so several years ago, we tried to do this. And we participated in a study with a group in Houston. And the idea was that in a family trees, if you have members with an aortic aneurysm, maybe the risk of having a brain aneurysm is higher. Unfortunately, we were unable to demonstrate this completely. However, there's a condition which is called the Marfan Syndrome, for instance, some genetic conditions. When a patient has some problems, aortic aneurysms, they have a higher incidence of brain aneurysms. So the message is the following. There are conditions where patients develop aortic aneurysms. And so if they develop that, maybe the chances will be higher, but there's not a scientific proof that this is the case. So you need to go case by case, unfortunately.
Thank you so much.
The answer is, if somebody has an aortic aneurysm, I would not go screening for brain aneurysms, okay, unless there's some overwhelming reason to do that.
Thank you, Dr. Zuccarello. That's all the time we have for questions, and we appreciate you being here with us today.